Hello, participants. I welcome you to the project of Clinical Key for Electrical Stimulation and Physiotherapy and Rehabilitation. This project is funded by the Erasmus Plus program of the European Union, and the leading University of Pamukkale is one of the partners, and other partners of this project are University of Craiova, Atay Mustafa Kemal University, Tashkent University, Suleiman Demirel University, Şule State University of Applied Sciences, and further Mehmet Akif Ersoy University. Other partners are Turkish Physiotherapy Association, Order of Physiotherapists in Romania, Lithuanian Physiotherapy Association, and Estonian Association of Physiotherapists. Now we are going to talk about functional electrical stimulation, which is the module 2 of currents used for electrical stimulation. Authors of the stimulation. So it's me, Dovydas Gedrimas, and my colleague Vaida Aleknavičiūtė-Blonskė in Šiauliai University of Applied Sciences, Faculty of Healthcare, Department of Rehabilitation, Šiauliai and Lithuania. So to begin with, the functional electrical stimulation has long been used in orthopedic and neurological rehabilitation. Its efficacy and application are well documented, and diagnosis from knee osteoarthritis to stroke. The acronym PES is probably the most commonly used in the literature. However, a distinction should be made that this method of electrical stimulation usually refers to the process of pairing the stimulation simultaneously or intermittently with the functional task. In order for electrical stimulation to be classified as functional electrical stimulation, muscle contraction needs to occur during a meaningful functional activity. This stimulation may be timed specifically to contract when the particular muscle is meant to contract during a task, but not necessarily so. PES has also been described as the stimulation of impaired muscles to augment task-specific movement to improve motor control with time. By achieving a muscle contraction during functional activities, it is believed that the muscle may learn how to contract actively over time, and the strength gains may allow for the weaning of machine use with time. So, in practice, we ask the patient to contract the muscle with the electrical stimulation, and while during this process, the muscle gets stronger, and then the patient can start contracting muscle without the help of the stimulation device. But as I mentioned before, the necessity is that this electrically induced contraction should be used together with active muscle contraction. And functional electrical stimulation can be used to maintain or increase range of motion, reduce edema, promote healing of fracture or tissue, reduce muscle spasm and the effects of spasticity, improve circulation, prevent or reverse disuse atrophy, facilitate movement. It can also be used for neuromuscular re-education and orthotic substitution. Recruitment of motor units by electrical stimulation progresses from large to small, the reverse order of voluntary contraction, because axons of the largest diameter are the easiest to activate. And voluntary contractions preferentially recruit force-producing slow contraction, fatigue-resistant type 1 fibers before more forcefully, faster, fatigably type 2 units. So it's a reverse order of the recruitment than voluntary contraction. And this allows for asynchronous activation of varied muscle units, which enables smooth switching between active and inactive motor units to maintain muscle activity, while allowing recovery time for individual motor units and for smooth and graded movement. Electrically elicited contractions lack smooth, gradual onset, reflecting biased and synchronous motor unit recruitments, but it happens because the recruitment order is reverse. So we can reduce this not smooth, not gradual onset by asking the patient to contract muscle together with electrically induced contraction. So we should talk about the parameters of electrical stimulation. So the main parameter is frequency. So the frequency refers to the pulses produced per second during stimulation and is stated in units of hertz. So how many hertz are shown? So as many pulses per second occur. So in this example, 40 hertz means that there are 40 pulses per second of electrical current. And the frequencies of electrical stimulation used can vary widely depending on the goals of the task or intervention, but most clinical regimens use 20 to 50 hertz patterns for optimal results. In order to avoid fatigue or discomfort, constant low-frequency stimulation is typically used, which produces smooth contraction at low force levels. Higher frequencies are generally reported to be more comfortable because the force response is smooth and has a tingling effect, whereas lower frequencies elicit a tapping effect where individual pulses can be distinguished. Ramping of stimulation frequency. So frequently, a gradation of stimulation up the desired frequency and intensity is used for patient comfort. And ramp time refers to the period of time from when the stimulation is turned on until the actual onset of the desired frequency. Ramp time is used in clinical applications when a patient may have an increased tone that creates resistance against the stimulation movements. Then we can use longer ramp time intervals. For instance, a person with flexor hypertonicity at the elbow would benefit from a gradual ramping up of stimulation frequency to allow more time to activate elbow extensor moving in opposition to tighten flexors to successfully complete the movement. So the longer the ramping time, the more time there is to activate muscles to the desired level. Pulse width or pulse duration. So electrical stimulation devices deliver pulses in waveform patterns that are often represented by geometric shapes such as square, peak, or sine wave. The time span of a single pulse is known as the pulse width or pulse duration. A study comparing 50, 200, 500, and 1000 microseconds pulse width when 20 Hz stimulation was delivered, the soleus muscle, found that the wider pulse width produced stronger contractions of plantar flexion and additionally augmented overall contractile properties. In addition, longer pulse durations will typically penetrate more deeply into subcutaneous tissues, so these widths should be used when trying to impact secondary tissue layers. This example can be used to other muscles as well. So if we have 20 Hertz stimulation, so we have 20 impulses per second, so we can change the duration of these impulses. So it can be short, for example, for 50 microseconds. It can be longer and as long as 1000 microseconds per one impulse. A duty cycle describes the actual on and off time of a neuromuscular electrical stimulation. Program end is usually stated in ratio form, such as 1 to 2. For example, if we have 10 seconds on time, so then there should be 20 seconds off time. Or percentage, such as 70%, indicating time on percentage when compared to total on and off time combined. Common clinical applications use 1 to 3 duty cycles as standard, but this ratio can be modified to accommodate the needs of the patient as well as the goal of the treatment. So the first number shows the on time, and the second number shows the off or rest time. Another parameter that will contribute to fatigue is the strength of the current being administered or the intensity or amplitude, usually reported in milliamperes, with which the stimulation is delivered. The higher the intensity, the stronger the polarization effect in the structures underlying the electrodes. Higher densities can foster increases in strength. Strength gains are consistently found following training with electric stimulation programs. Lower intensities can induce more central nervous system input than higher intensities. Intensity will also factor into patient comfort, with the higher intensities are typically less tolerated. However, frequency and intensity inevitably will determine the quality of muscle contraction produced. The success of the functional electrical stimulation current to reach the underlying tissue is highly related to the electrode size and the electrode placement, as well as conductivity of the skin-electrode interface. Larger surface electrodes will activate more muscle tissue, but will disperse the current over the wider surface area, decreasing current density. Smaller electrodes will concentrate current densities, allowing the focal concentration of current with less chance of stimulation crossover into nearby muscles, but dense current increases the chance for discomfort or pain. Usually, a positive red pin electrode or anode is placed near the upper insertion or top of the muscle. Negative black pin electrode cathode must be placed at the motor point of the muscle because it elicits stronger and easier contraction. The motor point is usually located at the center of the muscle mass, where the motor nerve enters the muscle. To find the best position, the physiotherapist may slightly move the negative electrode around and to search the best place where the most muscle contraction is produced. The main objective is to find a spot where the minimum amount of electrical stimulation will easily excite the greatest muscular contraction without causing pain. The effectiveness of functional electrical stimulation also depends on electrode size. The optimal electrode size depends on the target muscle. For example, small electrodes are more precise than larger ones for selective activation of forearm muscles, for example. However, accurate positioning of a small electrode may require more time than a large electrode to test over the skin surface of the target muscle, so we take more time to find the precise point where the best position is for muscle contraction. The location of the stimulating electrode is critical for eliciting the desired muscle contractile response, and positioning the electrode close to the sensory nerve may lead to the activation of the skin surface receptors and cause discomfort. In this example, we can see the electrode placement for quadriceps femoris muscle strengthening. So left side is with self-adhesive cord electrodes, and the right side we have self-adhesive wireless electrodes, but the principle is the same. So one electrode is placed on the origin of the muscle, and the other electrode is placed on the motor point of the muscle. And in this case, we can see a functional electrical stimulation because there is a electrically induced muscle contraction, and also we can see voluntary movement of infraspinatus muscle. So external rotation is performed here, and also electrical stimulation is electrical electrodes are placed on the infraspinatus muscle to increase its function. And the same principle applies here. One electrode is placed on the muscle origin, and other electrode on the motor point of the muscle. Indications for functional electrical stimulation. So it is applied to improve muscle strength and prevent muscle atrophy, to improve and maintain the range of motion around the joint, reduce muscle spasticity and spasms, to increase cardiovascular function through the activity of large muscle groups. Contraindication are demand cardiac pacemaker, implantable defibrillator, or unstable arrhythmia, placement of electrodes over the carotid sinus, areas where venous or arterial thrombosis or thrombophlebitis is present, pregnancy, over or around the abdomen or low back. Also, exceptions are when electrical stimulation may be used for pain control during labor. When contraction of the muscle may disrupt the healing, for example, muscle or tendon tear, overuse, or acute injury. And precautions are cardiac disease, impaired mentation, impaired sensation, malignant tumors, areas of skin irritation or open wounds, may cause delayed onset muscle soreness. So that should be mentioned to the patient in advance. And thank you for your time for watching this presentation.